All right, so I went ahead and I began the recording. If at any point you guys need to stop me, unmute yourself, raise your hand, pop in the chat. You've got questions, just please let me know. So we're going to start out with our endocrine side of things. And when we think endocrine, we think hormones. So specifically, we're going to address our pituitary gland because our pituitary gland is just a house of pretty much most of our hormones. Originate from the pituitary gland. The pituitary gland produces something that helps them, whatever. Just know with the pituitary gland, it's in the middle of our brain. So if we have any issue with our brain, such as head trauma or a brain tumor or increased intracranial pressure, all of that can have an effect on our pituitary gland. Okay, so just keep that in mind. Our brain is very fragile. It's, again, our fragile, closed box. Okay, so what do we have to be thinking about when we're working with the brain? So, specifically, our anterior pituitary gland. We're going to briefly define a couple of the disorders and some complications of treatment. Okay, really, we're going to focus on broad hypopituitarism, broad hyperpituitarism, and then we'll specify, some special diseases that are very common in the clinical setting. So again, this diagram is here for you guys. I just outlined what are our major hormones being produced and what do those affect. Okay. So when we're talking about hypopituitarism, essentially my brain is just not producing enough of these hormones. My pituitary gland is not producing enough of these hormones. So what happens? If my brain doesn't produce them, my body does not give them. So if we have any issue with my pituitary gland not producing, we're just going to have a lack of whatever that hormone does or produces. If we have a lack of thyroid hormones, we're going to have a lack of energy because thyroid hormones are our energy hormones. We have a lack of ACTH, we're going to have a lack of cortisol. If we lack growth hormone, we're going to be very, very small. Okay, and if we lack our gonadotropins, we're going to be missing those important sexual maturation characteristics. Okay, so just keep that in mind. Usually these are diagnosed via lab tests, but usually your patient will just report a lot of symptoms. Okay, again, we're really thinking broad. Okay, we're thinking more, okay, general concept of what's happening and what do I as the nurse need to do. So just know that if you have any form of hypopituitarism, what are we going to do? We're just going to replace the hormones. However, we're going to produce what the body is essentially lacking. So, for example, thyroid hormones. Well, what stimulates the production of T3 and T4? Well, TSH does. TSH gives me T3 and T4. But if I have hypopituitarism, I'm not going to give my patient thyroid stimulating hormone because for whatever reason, I'm not getting T3 and T4. Therefore, I give the patient what they are missing. So we look at what is the end hormone being produced. That's what we give them, okay? On the flip-flop, if I give them the hormones they're missing, I have the possibility of putting them into a hyperfunction of these hormones, which looks a lot like our hyperpituitary disorders. So in a few slides, we are going to cover the differences with ACTH and thyroid hormone, but just again, in general, what likes to cause hyperfunction? A lot of our tumors. So if we have a tumor on our pituitary gland, it's going to just light up these hormone control centers and we're just going to have mass production of these hormones. I do think it is important to know with a hypersecretion of growth hormone, we have two different pathologies, okay? If we have this hyperfunction after puberty, we have acromegaly. Think acro, think after, the A and the A. If we have gigantism, this happened before puberty, so they are going to be pretty gigantic. Okay? What are we going to do? We can give a lot of different medications, but medications have side effects. And if the cause is a tumor, will medications treat the underlying cause? No. So most often, if we have a hyperpituitary disorder, we are going to do a hypophysectomy. However, surgeons don't like to repeat their procedures. If you're having a craniotomy and you are going in and you are getting rid of a tumor, they're not going to try to excise out the good portion of the pituitary gland and really cut and try to get it out. No, they're going to go in, grab everything that they can, and get out. They get in and they get out. What does this mean? Not only are they removing the tumor, but they're also removing the pituitary gland itself. So now if I have no pituitary gland, I have no way of producing all those hormones. I can't produce ACTH. I can't get thyroid stimulating hormone or T3 and T4. I can't get growth hormone. I can't get everything. So if we had a hypophysectomy, we need to, one, care for the post-op hypophysectomy patient, but we also treat them now as if they were having a hypopituitary disorder. So after removal of the pituitary gland, they're going to have to be on lifelong hormone replacement therapy. Okay? Big general concept. Now, if we're caring for the patient post-op of a hypophysectomy, there's a couple things we need to look for. Number one, we're messing with hormones. We need to specifically be watching for DI, diabetes insipidus, when they are dry inside. They are producing mass amounts of clear, dilute urine. And they are thirsty, and they just keep losing weight and peeing and peeing and peeing. That's a big complication. Brain surgery, lots of swelling. What are we going to do? We're going to elevate the head of the bed. We want my patient's head to constantly be elevated to reduce swelling. So now's not the time to do cartwheels. Now's not the time to be doing yoga. So much so we don't even want them brushing their teeth, because even that will increase their increased ICP. So probably just going to have them use some mouthwash, swish and spit, things like that, and really emphasize the importance of nasal packing. Again, we don't want them sneezing. Why? That's going to mess with our brain's pressure, our skull's pressure. Okay, so what are we as nurses going to do? Well, we teach them to pack their nose. When we're switching gauze, we assess the gauze. If we see a CSF leak, how do we know it's a CSF leak? Two things. There's going to be a gold halo. Snot doesn't have a gold halo, but CSF does. Additionally, there will be glucose. Why? There's glucose in our cerebrospinal fluid. There is not glucose in our snot, okay? So just think big picture. If we have hyperpituitary function, if we have hyperproduction of these hormones, I get in, I take out the tumor. Now I have to treat them as if they had a hypopituitary disorder, because they require lifelong hormone replacement therapy. And I also have to watch for those post-op creamy brain issues, okay? So now we're going to talk about the posterior pituitary. When I'm talking about the posterior pituitary, I'm really focused on the production of ADH, antidiuretic hormone, our anti-peeing hormone, okay? So what happens when we have SIADH? Essentially, we have way too much ADH being produced. So I have too much of this hormone that is telling my body to hold on to pee. Okay? So what do these patients look like? Big and bloated. They're going to have massive weight gain. Okay? Also, it should say 1 liter is about 2.2 pounds. Don't worry too much about that. But what are our signs and symptoms of fluid overload? JVD, bounding pulse, pitting edema, wet cough, things like that. They are holding on to fluid everywhere. Not only are they holding on to fluid, but they are not peeing. You notice your patient has gone all day without peeing at all, and they have mass weight gains. I'm thinking SIADH is happening. Well, what are some dangerous complications? If I have mass fluid overload, it's going to throw off my salt to water ratio. So I'm going to be very hyponatremic because I have more water than I do salt. If we have any sodium imbalance, risk for seizures. So these patients will be on seizure precautions, okay? So just keep that in mind. And when they do pee, it's going to be very, very concentrated. It's going to be amber, dark yellow, okay? Because essentially they're just excreting some electrolytes, waste products, etc., but they're not excreting water. So what do we need to do? We need to get fluid off. Number one, get it off and don't put more on. So these patients mass fluid restrictions, strict INOs, seizure precautions. If we have to give them some sort of fluid, we mix meds or food with normal saline, okay? Keep that in mind. Additionally, hypertonic saline is a drug of choice to help use salt to pull that water out, okay? Additionally, diuretics are also very good drugs for these patients. On the flip-flop, we've got diabetes insipidus. They lack ADH, so they have no hormone that is telling them to conserve water. So essentially, the kidneys are just wasting lots and lots and lots and lots of water. So what are my issues with this? Massive dehydration and hypovolemia, which can lead to hypovolemic shock. Additionally, I have a bad ratio of salt to water, so my salt is significantly higher. But what do we know about sodium and potassium? They are salty bananas. They are opposites. If I have a high concentration of sodium, I have a low concentration of potassium. Now what am I scared about? I'm scared about seizures and dysrhythmias. So, is this a brain problem or is it a kidney problem? Well, if it's a brain problem, it means that my brain's not producing ADH or suppressors. Therefore, if I give that drug, it's going to work on my kidneys and that drug is going to help them. That's how we know it's a neurogenic issue. But if I give them the drug their brain is supposed to produce and it still doesn't work or help their symptoms, that means it's nephrogenic, meaning my kidneys are just not responding to this vasopressin drug. Okay, so what do we give them? We give them desmopressin. Okay, we can also give them some aqueous vasopressin, but again, similar concepts for care. We're doing our daily ways, and we're really cautious about their fluid and electrolyte balances. Additionally, we want to replace everything. If you peed out a liter, I'm giving you a liter of fluid, and just kind of continue from there. Okay. So now we're going to talk about the adrenal gland. So adrenal glands are actually on our kidneys, and we have our adrenal cortex and our adrenal medulla. What on earth does our adrenal cortex do? Essentially, the adrenal cortex gets stimulated by ACTH, which comes from the anterior pituitary gland, so it's all related. But my adrenal cortex gets stimulated by ACTH to increase my blood glucose levels. Additionally, it also helps secrete aldosterone from our good friend, the RAS system. Adrenal medulla, this is on the middle, and this helps with our fight or flight hormones, epinephrine and norepinephrine. So now we're going to talk about Cushing's. So what's happening? My adrenal glands are secreting way too much sugar. Okay. What are some negative effects of sugar? Puts you at risk for infection, weight gain, lowered immunity. You have all this hypertension, fluid overload, all the above, okay? And a little bit of that also comes from that excess aldosterone being secreted. But with Cushing's, we really need to kind of figure out what the underlying cause is and kind of treat accordingly. So if my brain is producing way too much ACTH, and that's what's causing the excessive cortisol production, they know it's a pituitary cause. But if my brain's not producing a lot of ACTH, and for whatever reason, my kidneys are like, you know what? Let's just secrete some more sugar, then I know it's a adrenal issue, okay? So a lot of our nursing considerations for Cushing's are going to be kind of about management. Don't abruptly stop taking steroids. These patients are at increase for infection, so we want to kind of be safe around them, manage their hypertension, a lot of weight gain associated, so proper skin assessments and skin care. Okay? That's going to be our general considerations for Cushing's. Addison's, kind of the opposite. I don't have enough aldosterone and cortisol being secreted. So what do we know about sugar? Sugar gives us energy, okay? It's kind of what our body can use to help function. We need sugars. That's why it's super bad to cut out all sugars from your diet. Also, we're losing aldosterone. So if you remember our friend aldosterone, he saves sodium and pitches potassium. So he's going to hold on to salt. What do we know about salt? Where salt goes, water flows. It's going to help pull water. The problem with aldosterone is it gets rid of potassium. So what happens if I'm lacking aldosterone? Well, I'm no longer saving sodium and saving water, so my fluid levels drop in the body, but I'm no longer getting rid of potassium, so my potassium levels are going up. And increased potassium levels can cause cardiac dysrhythmias, okay? But what's the issue with Addison's? Okay, Addison's can be a chronic disease, but what happens when a chronic disease becomes acute? This is when we have adrenal crisis. We have severe hypotension with severe hyperkalemia due to everything that I just said. Okay, so really, what are we going to do? We're going to kind of figure out what's going on with these patients and what do we have to do? Yes, Natasha, quick question. What's up?
What's the difference with someone having Addison disease and someone that's having diabetes insipidus?
So with Addison's disease, this is caused by a lack. They also have very low sugar issues. So with diabetes insipidus, my kidneys are not holding on to water because my kidneys are lacking ADH. That's the cause of diabetes insipidus. They don't have ADH, therefore they have no anti-pee hormone, so they're just going to be peeing like crazy. With Addison's disease, it's a different cause, but they are very similar. Essentially with Addison's, it's due to that loss of aldosterone and cortisol. Okay, the aldosterone contributes to that lack of blood volume because we have multiple different ways the body can conserve water. Okay, this is just a different pathway. But with Addison's disease, think that we have very low sugar, very low fluid, and very, very high potassium. Okay, does that help at all? Okay, awesome. So body has a lot of different pathways it can kind of go to save water. Aldosterone helps us conserve water, but it will get rid of potassium by doing so. So with this disease, they have very low sugar, very low blood pressure due to the fluid depletion, okay, and very high potassium. So low sugar, low BP, but really high potassium. And that's what we have with Addison's disease. So focus on your adrenal crisis, okay? These patients are severely hypotensive, severely dehydrated, but have mass amounts of potassium. So while a low blood pressure is dangerous, what's even more dangerous is potassium imbalances, okay? So what do we have to do? We have to get that potassium off. What are we going to do? Kayexalate enema, okay? One thing to note, the whole purpose of the kayexalate enema is to help them poop out potassium. Therefore, we don't want them taking antidiarrheals because that kind of negates the fact. I know it's not the most comfortable thing, but we have to get that potassium out, and that just so happens to be the quickest way. Additionally, we can give them some steroids such as prednisolone. Why? We're trying to increase the gluconeogenesis to increase blood sugar. That's what steroids do. They help with that. Okay, so steroids, lots of different uses. But really, watch for dehydration, watch your glucose levels, watch the cardiac monitor, and watch your INO. So now we're going to talk about pheochromocytoma. So essentially, yes, what's up, Ray? I know you have a question, Ray. You might be muted.
Hello, sorry, I was.
You're good.
Can you hear me?
A little bit, yeah.
Sorry. So, and let's say like in a crisis that a hypo like Addison's disease, if they have an emergency with like they're going to Addisonian crisis, would you first do the IV fluids first and then the steroid, or the steroid and the?
Great question. You would give them IV fluids first because steroids do take a good amount of time to work. So nurses do everything with fingers and toes. What we're going to do, we're going to bolus some normal saline, and then we're going to start them on steroids. Steroids are more used for that long-term management, but in the acute situation, we're focusing on what's the issue. The issue is hyperkalemia and dehydration. So we're going to tackle those two first, and then we can kind of tackle the sugar issues.
Perfect, thank you.
No problem. Good question. All right, so pheochromocytoma. Now we're talking about our adrenal medulla situation. So essentially, I have a tumor on my adrenal gland that is causing my adrenals to produce way too much epinephrine and norepinephrine. These are what are fight or flight hormones. They help raise our blood pressure and raise our heart rate and make us really go fight or flight. So a lot of your symptoms are going to be fight or flight symptoms. Okay. What do we as the nurses need to do? We need to get this tumor out. So before surgery, we do need to give some pheno. I just call it pheno. I'm going to butcher it. So we give them some pheno before surgery to just kind of help maintain the blood pressure and get them as stable as possible for pre-op. Additionally, what are our great meds that help us drop our blood pressure? Doxazosin, which is our Zosins, and then tolazoline. Calcium channel blockers are great. Beta blockers are also great. What do I as the nurse need to do? I need to write a do not palpate the abdomen sign and stick it above their bed, because we do not want to start touching their abdomen. Why? If I start poking that tumor, the tumor can kind of secrete more epi and norepinephrine. So this will help you with shock. What do we do if my patient's having a hypertensive crisis? They're in the upper 200s. I elevate the head of the bed because I want to make sure that I don't have mass blood flow to my brain, which can kind of cause a stroke. What do I do if my patient's hypotensive? I lay them flat to help promote blood flow to the brain. So that's just a good nursing consideration. So now we're going to talk about our thyroid gland, one of my most favorite things to teach about. So if we can think of our thyroid as a dart, what happens when you hit the dartboard with your darts? You start racking up points. You start getting more and more points. So essentially, that's what's happening with the thyroid. The more my thyroid gets stimulated, the more T3 and T4 are being produced. Now, this is great on the day-to-day. If my energy is very, very low, I'm going to produce more TSH to kind of help spark my thyroid to give me more energy. That's what T3 and T4 are. They're just energy hormones. But what happens in a lot of our hyperthyroidism with Graves' disease, I have antibodies that attack my thyroid hormone or my thyroid itself. But what happens, it's just like those darts, where instead of TSH being the darts, antibodies are now the darts. So it's still hitting the thyroid, it's still having my thyroid produce more T3 and T4. But we learned a lot about hypothyroidism in Complex Health 1. So we're going to focus on our acute emergencies. So our acute emergency with hypothyroidism is myxedema coma. Essentially, we have such a lack of energy, my heart has no energy to pump anymore. With a hyperthyroidism, we have thyroid storm, meaning I have way too much T3 and T4, so I have way too much energy. Heart rate's up, BP's up, temp's up, everything is up. And when someone's having a hypertensive crisis, if the hypertensive crisis goes on long enough, eventually their heart gives out. And that's an emergency. Okay? So with hypothyroidism, again, myxedema coma, what do we know about all exacerbations of acute diseases? What do we know about all exacerbations of chronic diseases? They are triggered by response to stress. The body doesn't know the difference between stress from school, stress from illness, whatever. But when we have stress, we have decreased immunity, and we can have some chronic conditions becoming acute emergencies. So, patient with myxedema coma will have very low heart rate and blood pressure. They're going to be in and out of consciousness, very lethargic, very weak, all the above. Okay? How do we know it's a primary issue? This means that my thyroid itself is not working. So I have lots of thyroid stimulating hormone, but for whatever reason, it's not working on my thyroid. I'm having low T3 and T4. That's primary. Secondary means my brain is simply not producing thyroid stimulating hormone, and that's probably why I'm lacking T3 and T4. So what in the world do? We need to give them small doses of levothyroxine or Synthroid and put these patients on some hormone replacement therapy. Big black box warning with hormone replacement therapy, lots of bad side effects, blood clots, hypertension, things like that. So it's just something to be aware of. With Synthroid, we need to avoid calcium and over-the-counter vitamins and minerals for about 4 hours. So take this medication on an empty stomach alone. But similar to what we talked about hypopituitarism versus hyperpituitarism, if I'm treating a hypo disorder, I have the risk of over-medicating and it becoming a hyper disorder. Okay? So, hyperthyroidism, we're concerned about thyroid storm. So I have very, very hot, very hypertensive, tachycardic. This could lead to dysrhythmias. Okay, so just keep that in mind. Again, with primary, I have low thyroid stimulating hormone. For whatever reason, lots of T3 and T4 are being produced. So with primary, it's an issue with my thyroid itself. My thyroid's doing something wonky. If it's secondary, this means the cause is secondary to increased TSH being produced. So, what are some good drugs for these? Really, PTU and methimazole, very, very common. We can also give propranolol, which is a very good drug that lowers your heart rate very, very quickly. Fortunately, if this is due to like a cancerous situation of the thyroid gland itself, we can undergo iodine therapy. So please review your radioactive iodine precautions. NCLEX loves to test on those. What do you do if your patient's, under radioactive treatment, whether it be for, this disease or cancer? What do you do? What are some things you need to think about? Additionally, if they've had kind of their thyroid gland removed, we're going to be watching for like some respiratory complications such as stridor, hoarseness, etc. But whenever someone is having a hypertensive crisis, we put them in a cool, calm environment, semi-Fowlers, meaning we're elevating the head of the bed and we're frequently doing vitals. These patients are very hot. We're going to give them some ice in those critical areas. So now we're really going to talk about some blood sugar emergencies. I know they seem very, very similar, but there's one key thing that differentiates DKA versus HHS. There's some other small differences, but what is our main factor in contributing? If you're sitting taking your test and you say, is this DKA or HHS? What's the first question I'm asking myself? What do you guys think? What do you guys think? Absolutely. Ketones being present. Awesome job, guys. Yep, ketones. That's the first thing I'm looking for. Yes, I know your blood sugar's high. Yes, I know you're dehydrated, but I need to know, is this DKA or HHS? So I'm looking for ketones. And from ketones, we can kind of figure out what else might be happening. So with DKA, essentially, I have such a severe lack of insulin that my body is physically producing ketones. But what's the issue with ketosis and the production of ketones? By producing ketones, when the body is producing ketones, it generates acid. So when we're making and forming these ketones, acid is being kind of created in a sense. So when someone is going through ketosis, they will actually have metabolic acidosis. That's just what happens. It's a metabolic issue. Acid is being produced by the formation of ketones. So these patients are going to have metabolic acidosis. They're going to try to compensate for metabolic acidosis with Kussmaul respirations. And on those respirations, you might actually smell a fruity breath. So with DKA, they have metabolic acidosis, which leads to those compensatory Kussmauls, ketones in the urine, hyperkalemia, and dehydration. Okay, yes, dehydration is a risk factor, but excess sugar does cause dehydration as well. Okay, so what are we going to do? We need to safely lower blood glucose. I'm not dropping your blood sugar levels like right away. No, I'm not going to do that. I'm going to safely lower them and I'm going to rehydrate you. Okay. What are we going to do to educate our patient? Well, how did you get into this situation? Probably because you weren't closely monitoring your sugar and taking your insulin, and you were probably dehydrated or, drinking a lot of alcohol. So a lot of it's going to be treating them and then providing education so that this doesn't happen again. With HHS, my body still produces enough insulin to avoid the generation of ketosis. So that's great and well, but the issue with HHS is there is more severe hyperglycemia and more severe dehydration and fluid loss. What are we thinking when we're thinking fluid loss? Hypovolemic shock, a drop in blood pressure due to a lack of circulating blood volume. Dehydration in a nutshell. What do we do for these patients? We give them some regular IV insulin, but again, same concept, we safely lower their insulin. These patients also will probably require more fluid replacement, so just watch for signs and symptoms of fluid overload because we don't want them to be drowning in all this excess fluid. Okay? So now we're going to talk about cardiac fun stuff. So I have a couple EKG practice strips, and we're going to go ahead and name them and name some of our issues associated with these strips, okay? But before then, let's name this one. Let's do it. I think we've got it. So this shows up on your patient's telemetry. What's happening here? What in the world is happening? Great job, guys. So this is supraventricular tachycardia. If this were a 6-second strip, we have, I'm not going to count the one on the far left because it's not a complete one. So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. That's like 28, maybe my math is bad. So my heart rate's kind of close to 300, especially if we count the 2 on the ends. That is supraventricular tachycardia. My patient is extremely tachycardic, but why are they tachycardic? And why is this not, that's okay. Why is this not regular sinus tachycardia? Because sinus is not the underlying rhythm with this. See how we barely see the P wave? We know this is SVT because before my P wave even has time to fully begin, my ventricles already are contracting. So my ventricles are responsible for this rapid rhythm, okay? What happens during our P wave? That's the atria depolarizing. Atria depolarizes, it helps drain blood into the ventricles, and then the ventricles can squeeze across the PQRST complex. But what's happening, my ventricles are responsible for this elevated heart rate. Notice how we barely see a P wave. We probably don't even see one, to be completely honest, because before the P wave can do its thing, before my atria can do their thing, my ventricles are like, time to go. Let's go. Come on, keep it moving. So what's an issue with this? Poor perfusion. So as a nurse, if I see this, what am I going to do? I'm going to go do some vagal stimulation, vagal maneuvers on my patient. We can also push adenosine. Careful, there is a brief period of asystole when you push adenosine, and you will have to bolus with a fluid after. Impossible cardioversion. All right, what do we think about this one? Be careful, a lot of these things can be similarly named. Absolutely. Great job, guys. This is our VTAC. So essentially, I have absolute chaos just kind of happening. I have no PQRST. What do we know about VTAC? What is often our precursor issue to lead a patient to having a run of VTAC? What might I notice happening on the monitor first before I see VTAC? It's really important. What is VTAC? Great job, Rosies. So essentially, what is VTAC? It's a bunch of PVCs in a row, okay? So if I noticed in the beginning of the shift, my patient had occasional PVCs, then they had bigeminy PVCs, and then they started having a couplet, and then they had 5, which was a run of VTAC, and then all of a sudden, all I'm seeing is PVCs. This is ventricular tachycardia. So how do we know if it's stable versus unstable? You'll feel a pulse. Typically, with stable VTAC, you will have a normal QRS complex, maybe followed by a 12-beat run of VTAC, and then a normal QRS, and then, a run of VTAC. But usually with VTAC, it's a pulseless rhythm. So what do we as nurses need to do? First of all, assess for pulse and breathing. How's it treated? It depends. If they have no pulse, we got to do CPR and defibrillation. If they do have a pulse, we're probably going to have to give some antidysrhythmic medications. But focus on the no pulse part. All right, what do you guys think of this rhythm? What do we think about this fun one? All right, I'm seeing lots of VFib. Great job. Will my patient have a pulse with this? Do you have a pulse with VFib? Nope, you won't. Essentially, what's happening in VFib, absolute electrical chaos, meaning my ventricles just are going at an odd rate, no rhythm whatsoever. My ventricles are just opening and closing. But what's not happening? Blood is not pooling into my ventricles. Ventricles are not delivering blood anywhere. So essentially, my heart's just beating, but there's no perfusion being involved because blood is not draining, okay? What do? Assess for pulse and breathing. No pulse, no breathing, CPR, and defibrillation. What we do like about VTAC and VFib is that although they are lethal rhythms and there will be no pulse, we can defibrillate pretty early on because in order for a defibrillator to shock all the electrical activity out, there needs to be electrical activity. There is electrical activity with VTAC and VFib. This is why these rhythms are very good in responding to cardiac arrest because we can shock pretty early. And the earlier we shock, the better not only our chances for survival, but also good quality of life. All right, what about this one, guys? What do we see about this fun rhythm? All of these, I think all of these are pretty fun. All right. And so we got torsades. Does anyone want to tell me what is our main cause of torsades? This one's actually torsades. We know that this is torsades and not artifact because we see a very nice corkscrew helix. With artifact, it wouldn't be this nice kind of corkscrew. It would just kind of be all over the place, very tall, very, all over the place. That's artifact. That's just your patient moving. Yes, there's a big black box warning. All antidysrhythmics can further worsen dysrhythmias, which makes absolutely no sense because the whole purpose of that drug is to make sure that my dysrhythmia is managed. But antidysrhythmics can cause or worsen dysrhythmias, specifically amiodarone. I have it on the next slide. So, history of amiodarone use, big risk for torsades. So, what do we assess for? Obviously, pulse and breathing. They'll probably be breathing, probably have a pulse, but they'll be very dizzy because there might be some perfusion issues. How do we treat this? Magnesium sulfate. And last but not least, this one. This one's great. I mean, not really, but you guys got it. I believe in you. Right? CPR. He's like, I don't even care. All right. Yes, it's asystole, and yes, we have to do CPR. Can I shock this? Nope. What does a defibrillator do? It removes electrical activity so that the heart can kind of be, no, but on Grey's Anatomy, yes. Absolutely, every episode, asystole, get the paddles on, charge to 200. No, absolutely. Oh my goodness. But in asystole, you cannot shock on asystole. What does shock do? Remove electrical activity so the heart can say, I'm no longer overstimulated. I'm ready to try again. And that's really in a nutshell what an AED does. But there's a complete absence of electrical activity, so there's nothing the AED can even shock. Very good job, guys. So now we get to talk about some of our other cardiac stuff. Not as fun as EKGs, but I think they're still kind of cool. So first up, we're going to talk about endocarditis. Specifically, we're going to pay attention to what signs and symptoms our patient's going to show and what we kind of need to do. So all you need to know is there's an infection on the inside of the heart. Well, how in the heck did the inside of the heart get infected? It's protected by the outside of the heart. Well, somehow an infection got in. Well, what goes inside the heart? Blood. So usually it's from an infection in the bloodstream. Okay? Usually this will contribute to our mitral valve being infected, which can contribute to the development of heart failure if I have mitral valve stenosis. What will we notice specifically about infective endocarditis is it kind of lyses red blood cells in a weird way. So you'll start essentially seeing dead lysed red blood cells all throughout the body. You'll see splinter hemorrhages in your fingernails. You'll see Roth spots, which are dots on the eyes. You'll see, petechiae, red rash, things like that. So that's pretty indicative of infectoendocarditis. What do we need to do? We have to get blood cultures and an echo done. This is hallmark diagnostic criteria. Additionally, they will have a new regurgitation murmur due to that valve stenosis. So, what do we need to do? Number one, we've got to treat the infection. Penicillin and cephalosporin are drugs of choice. What are we going to do? Assess for signs and symptoms. Big thing with this is patient education, proper rest. They'll probably be on long-term antibiotics, so that goes through a PICC line care. And just think, what populations might be at risk for this? Now we have pericarditis, which is a little bit different from infective endocarditis. Essentially, my outermost portion of my heart is inflamed. Lots of different causes, so don't focus too much on your causes. Focus more on what your assessment findings would be. Really bad pain, aggravated by breathing, and this high-pitched sound. Because my heart walls are so swollen, they're now like there's no space in between, and they're just kind of grinding against each other. Is it significant to focus on the weird lesions, nodes, Roth spots for infectoendocarditis? Absolutely. I think it's important because those are hallmark signs and symptoms, meaning you're not going to have those signs and symptoms with any other disease process. That's what I mean when I say hallmark, meaning if I see this, I'm 99% sure that this is infective endocarditis. So absolutely, the Next Gen NCLEX loves to have case studies where they kind of like to compare things side by side. So how would you compare pericarditis to endocarditis? How are they similar? How are they different? So absolutely, we want to know those hallmark signs and symptoms. So our hallmark signs and symptoms with pericarditis is this high-pitched sound and precordial chest pain. Additionally, you'll also see a new or worsening pericardial infusion. So just keep those in mind. What are we going to do? We have to correct the underlying problem. If it's due to infection, we're going to give some antibiotics and possibly drain that. If it's caused by a kidney issue, dialysis. Additionally, colchicine is a really good drug to help prevent this reoccurrence. As nurses and my patients in a lot of pain, we obviously don't want pain. What can they do to help with that? Sit up and lean forward. Now we have cardiac tamponade. So with cardiac tamp, think fluid. What happens is my heart's encasing, if you will, gets filled with fluid. What is this fluid? It's usually blood, okay, in the pericardial cavity. So this is the nice little coat, if you will, that likes to keep our heart nice and warm and snuggly and all held together. So what happens when some fluid gets in between my heart and its little protective coat? Fluid buildup. What happens when fluid builds up? My heart can no longer expand very well. So what happens when my heart can't expand? It can't contract, it can't get blood out to the body, but it also can't take in new blood. So this leads to those heart failure signs and symptoms. So rocking the body with fluid. Fluid is getting stuck in the body and it's getting stuck in the lungs. This is why they do have some pulsus paradoxus as well. Okay, so just keep that in mind. They're going to have decreased cardiac output, but they're going to be fluid overload. Their lungs are drowning in fluid, their body's going crazy, etc. Treatment, get the fluid out. Usually they can like drain it out, they might cut a window, whatever the case may be, just kind of keep that in mind. What do we as nurses need to do? We need to continuously monitor our patient, specifically for Beck's triad. This is, again, hallmark sign and symptom of cardiac TAMP. Drop in blood pressure, followed by JVD and muffled heart sounds. Why are the heart sounds muffled? Well, when my patient has pneumonia, why are their lung sounds muffled? Because fluid surrounding the area. Why do they have JVD and hypotension? Well, number one, decreased cardiac output because of no squeeze. But also, my heart can't fill anymore because it can't, expand to accept more blood. So they have massive fluid backup. Big thing is JVD. Okay. Now we're going to talk about aneurysms. So forgive me for aneurysms. We're going to briefly talk about the differences between each of the three aneurysms because for the most part, they're all treated the same. Really, we're going to focus on how would our assessment findings differ to help us know what type of aneurysm this is, and then how do we care for aneurysms, specifically in the thoracic chest belly area. Not up here yet. Alrighty, so with a triple A, it is an abdominal aortic aneurysm. So what are we going to have? We're going to have a lot of tummy symptoms. So gnawing pain, pulsating abdominal mass. If we actually put our stethoscope over that mass, we will hear a bruit. If it's in a triple A, we don't touch the tummy. Okay, again, write out your do not palpate the abdomen sign. Stick it on the top of the bed. Okay, what can we do? We can get a CT with contrast. Again, basic intervention for lots of aneurysms. What are we concerned about? We're concerned about rupture. What happens? I have a hole in an artery. So instead of all my blood going through the artery and going to the body where it needs to go, it's going to go out that hole. It's not going to be in circulation anymore. My patient's going to be severely hypotensive. So if we suspect a rupture, I'm scared for hypovolemic shock. Okay? Big consideration. What do we need to do? We want to do everything we can to not let that thing rupture. What can cause an aneurysm to rupture? Hypertension. So manage their blood pressure. We're going to give them antihypertensives. We're not going to be knocking on the door and disrupting them 27 times. If their wife found out their girlfriend is also there, we're not letting them in the room, okay? We're really trying to lower blood pressure and lower stress. Okay. Yep. Now's not the time to be having a family intervention affair. Not the time for it. Definitely not. TAA, same concept, except now we are in thoracic. So think thoracic, think upper chest. We're thinking cardiothoracic. So this is up more towards our aorta in the heart. So we'll actually have more chest, lung, throat symptoms such as shortness of breath, hoarseness, difficulty swallowing. And again, I have a nice breastbone, okay? I've got some rib cages in place. You're not going to be able to palpate something underneath there, okay? Those bones are there to help protect my heart, okay? What they might, if you suspect a rupture, yes, you're going to see hypotension, altered level of consciousness, diaphoresis, absent pulses, things like that. But with this, you might actually have a lot of back pain as well, okay? Again, same nursing considerations, stress-free, antihypertensives. Keep them cool and calm, okay? Now we're going to talk about an aortic dissection. This is probably one of our most lethal aneurysm issues, okay? So again, what are we seeing if we suspect this? A lot of pain, lots and lots of pain. sweating, pallor, etc. What do we need to do? We need to get a bedside CTA. However, if it's way too unstable to get that, we need to do a bedside transesophageal echo. Okay? So, what are we going to do? Again, keep that blood pressure low. We need to prepare for the worst for this one because this one is the worst. So, manage their blood pressure, get some 2 large bore IVs just in case there is a rupture. We have to do massive fluid transfusions. You need 18 gauge. 18 gauge you can use for anything. We can use for fluid and we can do for blood. Okay? Don't put a 23 in their arms because when push comes to shove, they're going to have a really hard time bolusing that. Okay? Awesome. So now we're going to talk about shock. The big, fun, grand issue that everyone loves to learn about. So, lots and lots of different types of shock. We have hypovolemic. We've got cardiogenic. We've got septic shock, okay? Shock is just a fancy word for low blood pressure, and it's classified by what's causing the low blood pressure. If it's due to lack of circulating blood volume, hypovolemic shock. If my heart's just simply not pumping enough blood out, and that's making my blood pressure low, cardiogenic shock. Okay, so just keep that in mind. So, the body, pretty darn awesome. It's going to try to compensate in every way it knows how. Unfortunately, as critical care nurses, we have to look at things with a critical eye, meaning, yes, my body's going to try to compensate. So what are those subtle signs and symptoms that indicate my patient might be in shock or in the early stages of shock? Okay? So, we're going to talk about all those fun stages. So I know this says stages of hypovolemic shock, but this is kind of indicative of all the stages of shock. So yes, I know it's a lot to take in, but I do believe it is important to know your stages of shock. So just please know your stages of shock. Doesn't have to be super detailed, but you need to kind of know what signs and symptoms are happening so you can figure out how far along your patient is. So in our initial stage, my MAP is slightly increased, but it can still be pretty normal. My cardiac output is also normal. However, you'll see a slight increase in vital signs. Slight increase in heart rate, slight increase in systolic blood pressure, and slight increase in our respiratory rate, okay? That is pretty indicative of this initial stage. Okay, they might start, you might just notice that their heart rate's up a little bit and they're breathing a little bit heavier. Okay, but other than that, everything else looks normal. So be thinking, which one of my patients might be at risk for shock? And what are those risk factors? I had a patient go into shock and I was sitting there thinking, I was like, what could be the cause? Well, it could be this, or well, I know she's in here for an infection, so you know what? It's probably septic shock. Okay, so just keep that in mind. In the compensatory stage, this is when I start having more obvious signs and symptoms, but my body is still compensating. My MAP, again, still slightly decreased between 10 and 15, but now we're going to start seeing some acid buildup, some potassium buildup. You're going to start noticing they're probably not producing a lot of urine anymore, and they just feel very anxious and very, very thirsty. This is because my RAS system is kicking in, my renin-angiotensin system, okay? Renin-angiotensin-aldosterone system, okay? Again, there's still, we need to figure out what's going on because we have to treat the underlying cause. But again, compensatory stage, they're okay, but they're not great. In the progressive stage, now we have a life-threatening emergency. My MAP is severely decreased, and you will start seeing this cool, clammy skin. They look on the brink of death, okay? And they might feel some impending doom. And then unfortunately, if we still haven't figured out what's the cause, they can go into this refractory stage. In the refractory stage, they have risk for MODS, okay? Loss of consciousness, non-palpable pulse, they basically look dead, okay? What do we do for someone in the refractory stage? all we can do is intubate and give pressors because my body's own compensatory mechanisms are not working. So I have to give pressors because that's the only thing that will bring up my BP. Also, they're barely breathing on their own, so we need to intubate. So again, hypovolemic shock, we talked a lot about our lab values. Remember, these patients will have a buildup of carbon dioxide. They're going to be pretty acidotic and a low MAP. Okay, again, your signs and symptoms are more specific to the stage of shock. That's why it's important to kind of have a general understanding of the different stages of shock. Specifically with hypovolemic shock, dehydration and hemorrhage are big causes. Okay. What are we going to do? Again, if their BP is low, we keep them low. Lower the head of the bed. Okay. Put them in reverse Trendelenburg. Okay. Or no, put them in Trendelenburg. That is when the head is lower than the feet. Okay. Really address the underlying cause. Cardiogenic, think pump problem. Why is my blood pressure low? Because my heart's having a really hard time producing adequate cardiac output. With inadequate cardiac output, we have drop in blood pressure. Okay, these patients will be pretty hypotensive and pretty bradycardic. One thing to note about this is a pump problem. This is not due to a lack of circulating blood volume. Therefore, fluids will not help. We can give a mass amount of fluids, but if the heart can't pump the fluids through, we're just going to overload them with fluids and it's not going to do much. What can we do? Help out the heart. Give the heart dopamine and digoxin. Again, review those signs and symptoms of dig toxicity. If your patient's seeing halos, please make sure you get a recent dig level, okay? Ideally, we want it less than 1.5. I also decided to include this slide about MODS. Essentially, this is multiple organ dysfunction syndrome. So with shock, we have drop in blood pressure. What does blood carry? It carries oxygen. If I have low blood pressure, my tissues and organs are receiving inadequate oxygenation. So again, MODS is kind of more our refractory stage 4 of shock. But just really, when we suspect my patient is in MODS, very thirsty, very lightheaded, decreased urinary output. Okay, this is that risk for MODS. This is why it's super important to keep our SATs between 94 and 96 O2, even if that means intubating these patients. Lots of risk factors: shock, trauma, and SEERS. Okay, but if my patient goes into MODS, they are at risk for cardiogenic shock in the future because with MODS, organs didn't receive adequate oxygenation. If my heart doesn't get adequate oxygen, that can permanently damage my heart. That can then put me at risk for cardiogenic shock. Okay? So now we're going to talk about sepsis and septic shock. So sepsis is just a whole body response to an infection. What do we do with sepsis and the kind of infection resolution process? Number one, capillaries become leaky. My fluid is pulled out of my circulation and it deposits in the interstitium, if you will. So essentially, they're dehydrated themselves. Also, part of our inflammatory response is getting that clotting cascade activated. So with sepsis, we dehydrate and then we have lots of clots being produced because that's just part of that whole process. That is sepsis in a nutshell. I dehydrated myself, I formed a bunch of clots, but then I wasted all my clotting factors, so now I won't clot. So risk for bleeds, okay? So just really, really keep that in mind. With septic shock, this is that drop in blood pressure caused by sepsis. We know with sepsis, capillaries become leaky, I dehydrate myself. So I didn't necessarily lose blood volume, I just lost circulating blood volume. My blood's just my volume, my fluids are just somewhere they shouldn't be. They're like depositing in like my andisposed tissue, okay? Which is just bad. So our 1 hour sepsis bundle, number one, measure a lactate level. We also always get a blood culture before giving antibiotics. If we give antibiotics and then get a blood culture, it could mess up our blood culture. So lactate levels in blood cultures, think labs. We do our labs first. Then we can put them on a broad spectrum antibiotic, and then we can start rehydrating them, okay, with some crystalloid. We really need to find where this infection is coming from, okay? So do a pan culture, culture everything. Sears essentially describes and contributes to what makes sepsis so severe. So Sears is kind of what's responsible for that, those capillaries becoming very, very leaky, lots of different, you know, immunomodulators going through the body, clotting factor, clotting cascades being activated. All of that is thanks to Sears. Okay, so when we have severe sepsis, this is when we know we have an infection, we have Sears, that's that drop in blood pressure, capillaries became leaky, they clotted, they wasted their clotting factors, they're not doing too hot, and then it's accompanied by organ failure. Okay, so with Sears, this is just kind of what is, when we're talking patho-wise, why is sepsis causing septic shock? You're asking yourself, how in the world did my patient go from having an infection to being in septic shock? Well, it's because their body had systemic inflammatory response syndrome. That total body inflammatory response that causes capillaries to become leaky, causes me to dehydrate myself, causes me to release toxic metabolites, causes me to use up all my clotting factors, causes me to now have nothing left to clot. Okay? So again, what do? Identify the underlying source, oxygen therapy. Remember, these patients lost all of their clotting factors, so we need to give them that back. Okay. So yeah. So before we begin practice questions, does anyone have any questions? I know it sounds like I blew through a lot of it, but really it's big picture. Put yourself in the nurse's role. Okay? Any questions before we do some practice questions? Are we going over myocardial infarction? We're not going to be going over myocardial infarction in this one. I have a whole cardiac myocardial infarction lecture already done. We also went over myocardial infarction last semester, so I really just wanted to focus on like new content. But if you want to rewatch our myocardial infarction portion, those videos are there for you guys kind of in the YouTube playlist. You can find them under Patho or Complex Health 1. But essentially, how we connect myocardial infarction, think connecting it to cardiogenic shock. If my heart was starved of oxygen, that causes permanent damage to my heart. Well, that might mean my heart can't pump effectively. What can that contribute to? Cardiogenic shock. Okay, so that's really how we talk about myocardial infarctions. I know cabbage was also on your review. Personally, I don't remember there being much cabbage material, so I would just review your cabbage checklist in your pre-class worksheet, because other than that, there's just not much for me to add to it. It's just one of those checklists. But if you have like a specific MI question, I can definitely answer that. But it's very, very, very basic MI stuff. Very basic. What do? Nitroglycerin, get them to the hospital, get them in an intervention, cardiac cath, all that fun stuff. All we're talking about in Complex Health 2 are what are some of the complications of myocardial infarction? Cardiogenic shock. Okay? Any other questions before we begin some practice questions? I'm sorry if I butcher your name, but yes, Izali. I probably didn't pronounce that right. I'm sorry.
Sorry, I didn't mean to raise my hand. I was trying to do the thumbs up.
Oh, okay. Got it. Well, I'll take that as a go ahead and let's begin some practice questions. So these practice questions are next generation NCLEX focus, because specifically I've noticed, and your professors have noticed, some next gen NCLEX questions, they're quite simple, but it's just like a culture shock, if you will. So you see the question, you get a little bit scared, and that's totally fine. So I just kind of wanted to introduce you to them, but also there's a lot I can talk about for these practice questions because they're a lot more complex. So again, it's just helping with that deeper learning. So I know they look kind of gross and scary, but I think they really help tie in a lot of important concepts. So let's talk about this one. This is another one of our famous indicated, contraindicated, and non-essential. When we're thinking indicated means, yes, we want to do this. If we see contraindicated, this means it could potentially be harmful. It could pose a risk to my patient. We absolutely do not want to do this. And then finally, non-essential, it means it won't make a difference, or it's probably not related to what the question's asking me. The question's asking me about shock, and it asks me, oh, review your patient's like dietary like preferences. Non-essential. That's not related to shock right now. Okay, so let's read our case study. We have a 42-year-old male that comes to the clinic because he's excessively urinating. Okay, he was diagnosed with bipolar and has been taking lithium ever since. Just scanning, during these 20 years, he's had a few episodes of mania, etc., etc. They think he might have a UTI or BPH. Here's your assessment findings. Okay. The client's diagnosed with drug-induced DI. Okay, that's the first thing I thought of when I saw lithium. So, of the following instructions, do you think they would be indicated, contraindicated, or non-essential? What do we think about the first one? Do you think indicated, contraindicated, or non-essential? What do we think about this one? So this one is actually contraindicated. Remember, diabetes insipidus, dry inside. We have too little water. So what does this do to our water to salt ratio? It throws it off. I now have way too much salt when compared to the little amount of water I have. So high salt is contraindicated. What do we think about drinking as much fluid as we need? What do we think about that? As I drink my fluid that I need. Yep, this one is absolutely indicated. Whatever you lost, we need to get it back. So probably going to have IVs in them, but we're also going to encourage, yes, please drink lots and lots of water. Absolutely. So what about telling our patient to take your medication only every other day if you need to urinate even more than you do now? Well, what do we think about that? Absolutely, it's contraindicated. Please take your medication as prescribed. Yes, we should never be telling our patient, oh yeah, like only take it like, maybe if you're having these, like take it every other day. No, that's only for PRN meds, like pain meds. But absolutely contraindicated. We need them to be taking their meds. Okay, great job, guys. What do you think about telling our patient to take naps to get rest? What do we think about that? Yep, this one is non-essential. So this also helps you guys with psychiatric class. One, there's not a problem of energy related to diabetes insipidus. Not related to that. But What do we know about bipolar? It's categorized by highs and lows. It's why we don't want them to stop taking their lithium, but we want them to keep taking their lithium. We want to keep them at a normal, level. They're probably lethargic due to their bipolar disorder. So it's not related to DI. That's why it's non-essential. What about telling our patient when you get up to urinate at night, drink a full glass of water at that time? Great job, guys. You are hitting the nail on the head. With DI, we replace the fluids we lost. If you went up to go potty at night, drink some more water. Now, do we tell everyone when you get up at night, go potty and drink water? No, but we know the patient has DI. We know they're losing mass amounts of fluid. So, yep, drink water. If you lost a liter, drink a liter. What about try to go as long as possible between urinating to increase your bladder's capacity? What do we think about that? Ray's like, what the heck? Absolutely, this is contraindicated, okay? This is not an issue of bladders being like too spastic. They literally just pee a lot because their kidneys are not holding on to water. So no, we don't want them to wait as long as possible. We're not trying to burst their bladder, but also that's not going to help with this. This peeing isn't an issue of urge incontinence. This is an actual hormonal issue. You guys did awesome. I have the rationales and the answers for you guys here, but we talked about all of them. So with this one, we have 4 things and we get to pick what we think might be happening, okay? We're thinking about what's their immediate risk and what's some potential risks. So we have a female in the ED whose family found her, maybe not that, sorry. 72-year-old female is brought to the ED by her family who found her vomiting from eating food that had been sitting on the stove for 3 days. She's somewhat confused and says she just wants to go to bed. She's always been independent in her activities. Her family says over the past 2 months, she has lost interest in visiting, eating out, and going to church. She has a history of hypothyroidism and hypertension, both of which have been controlled by meds. Her current vital signs are as follow. So, choose the most likely options for the info missing by selecting the list of options. So right now in the ED, what are the 2 things she's most at risk for? What do we think? Based on our current assessment findings, when you have questions like these, look at what the question gave you. Look at your vital signs. Absolutely, dehydration is one of them. Look at that blood pressure. Pretty low. She also vomited a lot. That really dehydrates you. What do we think is another thing she's most at immediate risk for? We have dehydration and what? What is she at most immediate risk for? This is immediate risk. Ray, you were actually right. Look at her respiratory rate. Do we like a respiratory rate of 10? That's your immediate concern. Airway, breathing, circulation, okay? Dehydration, that's that circulation. Respiratory, that's your breathing. Those are your immediate risks. Now, when we talk about during her hospital stay, Yes, she is at risk for falls, okay? Yes, we love all of that fun risk for falls. Anyway, and then the other answer is actually pressure injury. It gives you a great rationale why it's pressure injury, just because I guess poor perfusion and gas exchange have a pressure injury. I don't think you'd ever be tested on that. But just know this is a prioritization question. Immediate risk. What did her vital signs tell us? She was extremely dehydrated and she had really short, shallow, few respirations. And then risk for falls due to this low blood pressure and confusion. But you guys did really good. I'm proud of you. Just remember, what is immediate concern? Airway, breathing, circulation. Where are we going to find that information? Vital signs. They're called vitals for a reason. All right. Another indicated, contraindicated, and non-essentials. 40-year-old female has been admitted to a med-surg unit for management of severe hyperthyroidism. She has no known history of any other problems. On admission, she's hypertensive tachycardic with a core body temp of 101. So, should we encourage the family to stay with the client throughout the day? Indicated, contraindicated, or non-essential? So, hypertensive. Do I want family in there if I'm hypertensive? Even though this isn't an aneurysm, what do we do with hypertensive patients? We limit stimulation. Big number one, limit stimulation. So absolutely family being in there is contraindicated, okay? It directly poses a threat to their safety. If she wasn't hypertensive, yes, we want family in there. It helps them feel safe and comforted and belonged. But what do we know about Maslow's hierarchy of needs? Your self, safety, and comfort is at the top. Your basic needs are at the bottom. Hypertensive, basic need. Issue, get the family out of the room. Too much stim. What do we think about applying a cooling blanket? Do we think that sounds like a fun idea? Do you think it's contraindicated? Not really related? What do we think? So this one is actually indicated. We know that it's indicated because we look at her core body temperature. It's 101. So it's not heat intolerance necessarily. They have a fever right now. Yes, cooling. It's okay. It's just those little tiny words. What do we think about providing a low salt diet? It's okay. Happens to the best of us. What do we think about a low salt diet? So, I'll talk about this one. In general, if my patient has a history of chronic hypertension, we keep the sodium low. But in this case, we know that my patient is hypertensive due to their thyroid issue. So actually, for this, a low sodium diet's not essential right now, okay? That's not what's causing her hypertension, okay? It's due to excess T3 and T4. I don't think a question on your guys' exams would get that deep, but again, it allows me the opportunity to explain. So this one's actually non-essential. How do we know it's non-essential? Her hypertension is not related to sodium. How do we know this? She has severe hyperthyroidism. Okay? So, what do we think about this one? Ensure the door to the client's room remains open for better observation. What are we thinking? I love it, Ray. Shut the door. Quietly, shut the door. We want to limit stimulation. All right. What do we think about asking whether there is any possibility the client might be pregnant? What do we think about that? Do we think that? What do we think about that? That's an interesting question. I want to know the thought process. You guys are correct. It's indicated. Why would it be indicated and non-essential? What am I thinking of? Why is it indicated? Those are great thought process. Yes, we want to know because some meds are a no-no. She's having thyroid storm. Thyroid storm is an exacerbation of hyperthyroidism. What can cause exacerbations? What can cause exacerbations? Lots of great answers. Lots of great answers. The answer I'm looking for, pregnancy. Do you guys think pregnancy stresses out the body? Do you think it's stressful to the body? Absolutely. She's having a thyroid storm. She's having an exacerbation of hyperthyroidism, probably an exacerbation of her Graves' disease. What causes that exacerbation? There's some sort of stressor that's kind of, kicking in. Is there a possibility she could be pregnant and that could be causing her excess stress leading to thyroid storm? Absolutely. That's why we want to ask. In addition to great meds, we want to know what's going on, things like that. Great job. What about monitoring the vital signs hourly? What do we think about that? So this one is actually indicated, okay? We do want to frequently monitor her blood pressure, her temperature, things like that. Ideally, we want to regularly monitor it, but usually regular, like you'll see texts, they go every 4 hours. For her, we're going to probably do every 1 hour. Also, to piggyback, lots of the medications for hyperthyroidism are not safe for pregnancy. So we do kind of want to know what's going on. So you guys did really, really awesome. If it said Q15, that would be non-essential. That would actually be contraindicated if it was every 15 minutes. Why would it be contraindicated every 15 minutes? Absolutely, too much stress disturbance. If I went in there every 15 minutes, I want to, like, again, knocking on the door every 15 minutes, blowing up their arm every 15 minutes, sticking something under their tongue every 15 minutes. So for these patients, absolutely, it's indicated. We want to regularly be assessing her. We know her history. We know what's going on, but we're also not trying to be like, hello, sorry to bother you. Quick 10-minute assessment here. Yeah. What about keeping the room lighting dim? Keeping the room lighting dim. Absolutely indicated. Great job, guys. You guys are doing so well. I'm so proud of you. Great job. I don't even have to explain it. What about having the client ambulate in the hallway? Oh, goodness gracious. Yes, it's absolutely contraindicated. We want rest and relaxation. You guys did super, super awesome. All right. I have another one of these. These ones really, really help with prioritization, and that's really what we focus on with complex health nursing. Sorry, there's like two giant frogs on my window that like scared me. Okay. All right. So we see this DKA diagnosis. Patient's alert and oriented. She's having difficulty speaking because she's got an elevated respiratory rate with deep breaths. She's thirsty and tired. We got her on IV fluids and we're giving him some saline and insulin. So, due to my client's DKA and thirst, I'm currently most likely at risk for what? And I don't know why I highlighted hypoglycemia when I'm doing screenshots, I have to highlight something. So don't pay attention to the fact hypoglycemia is highlighted. That's just because I needed to get a screenshot. What do we think are my current risks? What do I need to tackle first? Because that poses the most immediate risk to my client based on my client's findings. All about prioritization. So again, guys, dehydration, beautiful, you got it, chef's kiss. Remember, immediate concern currently means immediate. Immediate concern, airway, breathing, circulation. Yes, I know you're hyperglycemic. Is your hyperglycemia going to kill you? No, but what can? What can? Dehydration and what? Hypotension. Great job, guys. Is a patient who has DKA at risk for hypoxemia? No, they're not. It doesn't affect their oxygen levels. Okay. Yes, they have metabolic acidosis, but they don't have respiratory acidosis. So O2 sats aren't really involved right now. So yes, most likely at risk for dehydration and hypovolemia. Now, during this day, what are some risks and complications associated with treatment? That's what the second part of the question is asking me. She's most likely at risk for complications associated with treatment. So while we're treating her, what do I need to watch for? Beautiful. Fluid overload. Awesome. We're giving a lot of fluids pretty quickly. And hypoglycemia related to insulin therapy. Awesome job, guys. You did very, very well. I like these questions because they really focus on prioritization and treatment. All right. I have another one of these fun questions. Indicated, contraindicated, and non-essential. Nurse is caring for a 40-year-old male client who presents to the ED with reports of chest pain. The client has history of hypertension and anxiety. He doesn't smoke and hasn't taken any medication recently. He's got a lot of suprasternal pain and pressure. What am I thinking is happening? If you haven't guessed it already, this is MI. So I didn't want to make like a slide going over MI stuff for you guys because you already know that. It would just be the same slide from Complex Health 1. This is now the complex health side of a myocardial infarction. So obtaining a 12-lead ECG, indicated, contraindicated, non-essential. Absolutely, it's indicated. Great job. We're suspecting MI, get a 12-lead EKG. If we suspect an MI, we'll be able to see it on the 12-lead EKG. What about administering supplemental oxygen? What do we think about this? It's actually contraindicated. Can anyone tell me why it would be contraindicated right now? And don't think too deep into it. It's okay. Don't think too deep into it. Don't think too deep into it. Absolutely, my O2 sats aren't low enough to indicate supplemental oxygen. We initiate supplemental oxygen when we're like 92-ish. NCLEX world, less than 90. Patient satting at 96. It's not non-essential because non-essential means it doesn't matter. I could or I couldn't. We don't want to. Why? I'm within normal limits. I'm not trying to over-oxygenate and put extra stress on my body, okay? Especially when I'm suspecting a heart attack. We only give oxygen if it's indicated. Why? As controversial as it is, oxygen's a drug. Yep. Great job. We have specific proof saying we should not be doing this. It's my vital signs, so that's contraindicated. What do we think about completing a detailed history on this patient? What do we think about that? So if we're suspecting an MI, have you guys heard of the 1 hour door to intervention window? So, yep. So we really need to kind of be nurses and like learn to prioritize things. So right now it's actually non-essential. While it doesn't pose immediate threat to the patient, we can do this later, if that makes sense. So we're going to do a focus assessment. We're going to do a cardiac assessment. Have you had this happen before? Do you have a family history of myocardial infarction? Have you ever been diagnosed with hypertension, heart failure, etc.? Have you been diagnosed with unstable angina? Do you have coronary artery disease? We're doing a focused assessment. So non-essential for that one. While it doesn't pose immediate threat, not pertinent right now. What about giving sublingual nitroglycerin as prescribed? Absolutely, it is indicated. What do we think about monitoring our vital signs every 30 minutes? So, it's contraindicated. So a couple different numbers. Here's where it gets tricky. It's contraindicated. We want it more frequently than every 30 minutes. However, with our nitro drug, if you go way back to pharmacology, if you're on nitroglycerin, we get a heart rate and blood pressure every 5 minutes with that drug. Okay? So it's actually going to be 5 minutes. But don't worry, you guys got the general gist of we're having a cardiac emergency. We need some frequent vitals. So great job. What about providing intermittent ECG readings? What do we think about that? Awesome job, Carly. C, we need constant. We need continuous ECG monitoring. If we had intermittent ECG monitoring, maybe like once every 15 minutes, I get an EKG read. We want continuous ECG monitoring, meaning my patient is staying on telemetry. From the time they get hooked up to telemetry, from the time they take their stickies off, I'm getting a visual of what's happening in the heart. Awesome job, guys. I have one more question for you guys. I know we're going a little bit over time. I do apologize. But this is the last question I have for you guys. Oh, yes, Natasha, you're confused. What's up? What can I help you with?
So the question said about EKG, not just telemonitoring.
So yeah, sorry. I apologize. EKGs and ECGs are telemetry. That's what they are. You'll hear those terms used a lot.
Okay, when I read the question, I meant like I thought it meant like a strip, like it's printing a strip, not just the monitor itself monitoring.
Yeah. So when you're on continuous telemetry, you can print any strip of any time. When you're doing continuous ECG monitoring, we can grab a strip from that, but also I'm constantly seeing what rhythm they're in. And if we suspect a myocardial infarction, I need a bit more data than just one screenshot of what happened. I'm not sure if that helped, but just think we want you on continuous telemetry, and they really won't. NCLEX doesn't like to test you on like, oh, like strips, as in like when do you print a strip? They're more about like big picture stuff like that. So we do want them continuously being monitored, so I always have an eye on their cardiac rhythm. Okay, last question. So, no problem. If anyone has any questions, please interrupt me. I do not mind. I love answering questions. 44-year-old male was admitted to the ED following an MVA. He's got extensive injury to the chest that's open and bleeding. He also has flank bruising and intense abdominal pain. He's awake and alert with lab values or vital signs as follows. Client's spouse is present at the bedside and reports he's diabetic with a history of seizures. So, lots happening. We've got motor vehicle accident. We've got bleeding. We've got normal temperature, elevated heart rate, low BP, sort of normal trending downward O2 sats. He's also diabetic. So, indicated, contraindicated, or non-essential. Should we insert a 24-gauge IV into the left forearm? I love it, Ray. The bigger, the better. We love that here. You're going to need an 18-gauge IV. Because I'm thinking you might need some fluids. I don't like those vital signs. I don't like them. So I'd rather poke you with a big one and like not have to use it than like have to poke you like 5 times. Okay, great job. Contraindicated. What about applying oxygen via face mask? Absolutely. Contraindicated. What are his vital signs? He's doing fine. He's okay. He's okay for now. We're good. 96. I like those numbers. What about administering crystalloid fluids? What do we think about that one? Absolutely. Crystalloid fluids, your normal saline. Great job, guys. Absolutely. His blood pressure is quite low. Let me give you some fluids. I also knew that he bleeding a lot. What about assessing the client's blood type and cross-match availability? What are we thinking about that? Absolutely, it's indicated. What if I need to do a blood transfusion? Absolutely, I need to know that. What about monitoring vital signs every 5 to 15 minutes? Absolutely indicated. We are suspecting shock. In case you hadn't made the connection, we're suspecting shock. We need some frequent vitals. What about giving some broad spectrum antibiotics? Giving antibiotics is part of our sepsis bundle. What type of shock do we think's happening right now? Hypovolemic shock. So we're going to hold off on the broad spectrum antibiotics. Yes, he has a chest wound that's open and bleeding, but until I assess his white blood cell count and assess for signs and symptoms of infection, I have no indication that there is an active infection. And I'm leaning towards hypovolemic shock, not septic shock. It's actually going to be contraindicated in this situation. What do we think about assessing the client's blood sugar? Absolutely. It's indicated. He's a diabetic. And what do we think? Oh, Mia, you have a question? I see your hand up. What's up?
Yeah, can you hear me?
Yes, I can.
My question was actually a while back. It was from the apply oxygen via face mask. So like this is the same thing where like obviously it's contraindicated. But like I just am confused with why it just wouldn't be non-essential. Like it's on 96%, so it's like, okay, that's non-essential right now. Like technically.
So non-essential, think I could do this or I couldn't do this. Another example of non-essential would be, I can't think of one right now. I'm sorry.
That's okay. I
but
just
with
think that's like that kind of continues to mess me up. Like it goes hand in hand in terms of like non-essential and contraindicated.
Yeah.
Because contraindicated would mean it's going to have an adverse effect, whereas non-essential means it doesn't matter right now.
Yeah, but hyperoxygenating our patient can actually have a negative effect on them.
Okay.
We're introducing more oxygen, which puts just more stress on the body. That's why we only give oxygen when we're having like episodes of hypoxia, because again, we learn a lot about like our tissue reperfusion injuries. Oxygen is an ion, it's a radical, so we don't want to over oxygenate our patient, if that makes sense.
Yeah, that makes sense. That's why
usually oxygen, it's contraindicated. It can actually cause harm. Non-essential means, yeah, I could give them oxygen or I couldn't, it would make no difference. Well, giving oxygen would make a difference. And in fact, it would make a negative difference in this situation.
Okay, thank you.
No problem. So I think we're on the last one, and it was pad the side rails in the ED. What do we think about that? So this one is actually non-essential. I get it, it's quite difficult, but based on our assessment findings, is there anything that might suspect my patient is currently at risk for a seizure? I know he has a history, but right now, based on my assessment findings, do I think that he, at this time period, when I have a lot of other things happening, of pertinence right now, is my client at risk for seizures right now in this very moment? That's why it is difficult. You won't get an exam question where you're really having to think deep about it. But this one's actually non-essential because while it wouldn't hurt the patient and it's not really going to benefit them right now, we don't have to worry about that right now. We could or we couldn't. Just based on my assessment findings, there's nothing telling me he's going to have a seizure right now. Yeah, he has a history of seizures, but what if he just had them when he was little? And this kind of is in the realm of prioritization. Right now, my priorities for this patient are getting his bleeding under control, getting his blood pressure up, managing his pain, kind of treating the vital signs. And then once I get everything else stabilized, okay, then I can pad the rails. Then I can do things like that. But again, I don't think you'll get a question that's that deep. But that's just kind of prioritization in a nutshell. You would fight that answer. Absolutely. And unfortunately, you haven't got to leadership class yet, but leadership class, we actually learn a lot about these prioritization questions where you prioritize current problems over potential problems. And personally, if I had learned that information in our critical care course, I feel like I would have been better off because it would have helped me with prioritization. But we prioritize current problems over potential problems. That's why it's categorized as non-essential. And with these next gen NCLEX practice questions, you'll have a little bit of leadership, you'll have a little bit of prioritization, you'll have a little bit of psych. You could have everything in one question. Okay? So thank you guys so much for coming and attending. I really appreciate it.